Okay, welcome to the sixth webinar. Today's on audit and quality improvement projects. We've got two speakers today. So the first speaker is Dr. Naadir, is a foundation doctor working in the South Thames Deanery. He graduated from the University of Bristol with a primary degree, with the incollated BSc in functional and clinical anatomy with honours. He holds an active interest in TNO surgery and currently serves as the VP of BOMSA, having co-founded the organisation, where he previously held the role as regional committees lead. Furthermore, he is also currently the medical student rep of BOTA. He has a keen interest in research, medical education, undertaking a postgrad certificate in medical education, and has previously been published in peer-reviewed journals, presented at national conferences, and organised national and international teaching series and conferences. Our second speaker is Mr. Abbas, and he read medicine at the University of Cambridge from 2012 to 2018 with a degree in physiology and psychology. He spent his medicine. He spent his foundation training at the Thames Valley Deanery. Following this, he completed his core surgical training in the East Midlands South region before obtaining an academic clinical fellowship in TNO in the East Midlands North Deanery. He's currently a trauma registrar at the Queen's Medical Centre and using his academic time to set up a trauma-themed PhD. He is also involved in multiple other projects ranging from flexor tendon outcomes to elbow dislocations. Throughout his career, Abbas has a strong involvement in audit and quality improvement, having completed multiple projects and coming runner-up in the 2021 British Journal of Diabetes Quality Improvement Awards for his work in management of diabetic foot ulcers using total contact casts. So without further ado, Naadir, would you like to kick off, please?
Hey guys, thank you, Hannah, for that introduction. So I am going to talk a bit about audits and QIPs, mainly focusing on what it is, how do you run it as a medical student and a foundation doctor, and give you a few examples of what I did as a med student and as a current F1. So just getting straight into it, what is an audit? Clinical audit is a way to find out if healthcare is being provided in line with standards and lets care providers, as in hospitals, and patients know where their service is doing well, identifying areas of weakness and how you could improve to reach that particular standard. The aim is to allow quality improvement to take place where it will be the most helpful, will improve patient care, and in turn improve outcomes for those patients. And they can be anywhere from local clinical audits at your local hospital, at your trust, at your GP practice, or national clinical audits. Some of you may have heard of StarSurge, which are quite famous in the surgical field for running audits nationally and regionally as well. And for people looking to start out, that's a great place to start. Just go on their website and have a look. They have several different audit projects running across the country. So looking at the NICE definition of a clinical audit, I've highlighted some of the key terms. Seeking to improve patient care through a systematic review of care against explicit criteria and through the implementation of change. So that in itself describes what an audit is, improving patient care and outcomes through a review against explicit standards and then implementing change to reach that particular level of standard and using further monitoring to ensure that that standard has been reached. So since most of this series over the past month or so has focused on research, so I thought it might be important to differentiate between what a clinical audit is and what research is. Research essentially focuses on discovering new information and explores the best way to do things and asks two important questions: what is the right thing to do and what is the best way to do it? While if you look at a clinical audit, it essentially is evaluating how well current best practice is being carried out. So how is practice, say, in your hospital being done? And are we doing it in the right way? And are we doing the right thing? And then implementing change to ensure you reach that particular standard. So that's an important distinction that you need to know before carrying out an audit. This is looking at the difference again. Clinical audits improve healthcare service, research improves knowledge. A clinical audit is practice-based, while research is generally more theory-driven, and is an ongoing process compared to, say, one-off projects. And a clinical audit never involves an experimental treatment or placebo, while research may involve experimental treatment or placebo. So just some important differences to note. So why is an audit important to me as a medical student or a foundation doctor or someone early on in their training? It is carried out at all times as the MDT activity. You know, people, you guys are medical students, having been in hospitals, most of you, some, and for some foundation doctors, you understand that lots of teams carried out audits continuously. So it's important to know what it is, how to do it, and how you can do it. And medical students and junior doctors' involvement in clinical audits, they are taken very seriously. It is compulsory for junior doctors. It's part of your ARCP process most of the time. And in medical school, for example, I had to carry out compulsory audits as part of that process. The good medical practice from the GMC state that all doctors need to take part in regular and systematic audits, take part in systems of quality assurance and quality improvement, and respond constructively to the outcome of audits, appraisals, and performance reviews. So as you can see, you know, it's embedded within our curriculum. You will see it happen most of the time, if not be involved in some capacity. So it's very important you understand how to do it and the importance of it. You will also help to improve patient care. If you take part in audits in areas of interest, for example, like TNO, it shows great interest. You can talk about it in your interviews. You will learn several transferable skills such as teamwork, time management, and the results can be presented at most conferences. You can even write it up for publishing, which in turn will give you extra CV points. And like I said, it is a requirement for UK junior doctors to progress in their training. So what is a QIP? Audits and QIPs essentially are the same thing. They involve reviewing current practices and designing ways to improve. The main difference being that audits measure against a particular defined standard, while QIPs do not necessarily have to do that. Examples of QIPs include improving patient experience, streamlining pathways for patients to minimize wait times, improving the well-being of staff, improving the confidence of staff in dealing with a particular situation, and say making information leaflets. There is no particular standard that you need to measure against, while in an audit there needs to be a standard. But they are essentially the same process. So how do you do an audit? So these 11 stages, if you break it down, you select a topic, you agree a standard of best practice, collect the data, measure it against that standard, feedback the results, and then you discuss, you know, in your group or whoever is supervising you, the possible changes that you can make to reach that standard if your data shows that you haven't met that standard. You implement those changes, wait a certain time to allow those changes to be implemented and take place before re-auditing. And then you collect a second set of data, analyze the re-audit data, feedback, etc. Audits happen in several cycles. You can have, most of the time it's a minimum of 2, but you'll find that if you go to your local audit department, there are several audits that have been started, maybe completed one cycle and never really kicked on. But most of the time for a good audit project, you need to have a minimum of 2 cycles, if not more. So this is again just speaks about what I just mentioned. So you define the standard, you collect the data, compare it with the standard, implement the change, close the cycle, and repeat. These slides will be available to you at the end of the series, so this is something that you can refer to. Some of you may have heard of the PDSA cycle, the Plan, Do, Study, Act. It's another way, you know, it's a simple way of kind of breaking down how to do an audit or a QIP. Planning involves, you know, defining the standards, plan the data collection, how you're going to do it, carry out that plan, collect the data, study it, compare it, and then act, you know, implement the change. I would recommend, you know, before you start a particular project, you refer to this, figure out how you're going to do each step, at least in one cycle or a couple of cycles, and that will help I'll streamline the entire process and make it easier because you'll know exactly what to do and you've planned ahead to do such things. So what makes a good audit topic? So I thought, you know, you need to consider some things when you're selecting your topic. Priorities for your trust hospital department is a good place to start. Going to your audit department and asking them, are there particular things that need to be measured, or where there are shortcomings and where change can be made to make that improvement. Issues that are topical in your department, or just going to say you're working on a general surgical ward, going to your consultant and asking, is there anything that needs to change, anything that I can do to do that. My audit that I'm currently doing in my F1 was just going up to a consultant and asking them, what can I do to change the current level standard of care. And there were several things that came up, and I picked the one that was most interesting to me. A topic in area of medicine that interests you, if you're interested in TNO, going to your local trauma and orthopedic department, asking, what audits are available. There will always be a ton of things that you can do. And like I said, doing it in an area that you may apply to in the future, it will be beneficial and something that you can talk about later on. And re-audits of previous projects. This is, like I said, there are several audits that have been done in your hospital that have only maybe done one cycle that need to be re-audited. You have the standard, you have previous data sets, you have what you need to measure, and it's quite simple to just get involved in that and complete maybe one or two more cycles. And as a medical student where you don't really know where to start and you're not sure where your interest is, those kind of projects are quicker, are easier, and will be the most truthful at the end of the day. So in terms of planning an audit, now we've already spoken about priorities and where you can start. I thought the SMART criteria is quite a good place to begin, making your topic specific, measurable, finding a standard that you can easily compare your data to, making it achievable. And I think these two things, realistic and timely, are quite important. Are you the right person for this audit? Say you wanted a medical student, is it easier for a medical student to assess 4-hour waits in A&E than rates of a certain technique being used in theatre? It's great that if you can measure the rates of certain techniques being used in theatre, but at the end of the day, especially at an early stage, you should do what is realistic for you and what is achievable for you. And getting involved in the process and knowing how to do it early on is probably more important than trying to go for something big that you don't quite understand. And timely, something that can be done quickly. I think this is very important because as a medical student, you spend anywhere between, let's say 4 months to 6 weeks in any specific rotation. As a foundation doctor, you have 4 months in your department. So finding a project that you can start, at least do one cycle within the time period you are there is important, because you can easily start something, move to somewhere else, you move to a different hospital, and then you might just forget about it, or you just don't have the time or the resources, to be commuting, etc., to finish off that project. If you can complete one cycle, you can always just hand it over to your friend, to a colleague to complete your audit. And they gain something out of it, you gain something out of it. So it's very important to make sure you keep that in mind. So essential tips, how not to waste your time when it comes to audits and QIPs, making it official. Always apply to make your audit official with your local audit department. It's just all you got to do is turn up to the local office, or you just shoot off an email saying, I want to do XYZ, or do you have an audit that I need to do? And then just register it with them. It's a very simple process. It takes maybe about 20 minutes of filling out some paperwork. But if you ever need evidence that you have done it and to make it official, that I recommend that you do that. And in turn, that makes your audit ethically sound as well, because generally your audit department will know if ethical approval is needed, and will ensure that patient confidentiality is met at all times. Employing a team approach is important. You involving different members. I think a lot of us want to do everything by ourselves, but sometimes that's just not feasible. Involve your friends, involve your colleagues, co-workers, and you will all get something out of it. You can all be leads, if you all do a certain amount of work, and it will make it quicker, and it'll make the whole project easier. I said this again, finding a topic with a clear acknowledged guideline and choosing a supervisor that can help you in the process in case you get stuck. Again, realistic with the amount of time. Ideally, having 6 months between cycles is great, but if you can only afford 2 to 3 months, then that's fine. But ensuring that you have the time to do a couple of cycles at least is important, or at least having, you know, some sort of planning to ensure that if you leave your department, someone will be able to carry out your project and it doesn't just get lost. So I just thought I'll end by giving you an example of what I did in medical school and what I'm doing right now. So in my second year, we had a placement with GP, and they wanted us to just collect some data. So I thought, you know, why not make the best use of this time by doing an audit, a 2-cycle audit. And I improved the use of the fever pain score and antimicrobial prescribing at my local GP surgery. So all it was collecting some data about has the fever pain score being used in my GP surgery for sore throats. And then I gave a talk at their local meeting. I put some posters up at the office and then waited about 2.5 to 3 weeks, re-audited the data, then implemented a change on the electronic system, which is surprisingly quite easy, and then re-auditing the data again. You know, it was simple, it didn't take a long time. And this is a snapshot of the poster that I presented at a regional conference. You know, I got a lot out of it. I learned how to do an audit effectively. I got a poster out of it, and it might not be, you know, something big and life-changing, but I got a lot out of that in the short space of time. And especially for medical students that I'm speaking to that are quite early on, you know, projects like this are important to get an understanding of how to do audits, and also just to get the most out of the times you are in your placements. So these are just like, this is the another snapshot of the poster that I presented. So in terms of, you know, we all talk about CV points, and at the end of the day, audits, for example, for core surgical training is gives you the maximum points. I think for this year it's 15 points for doing a 2-cycle surgical audit and presenting it at a conference. So if you need evidence to suggest that, so I thought I'll give you a picture of my letter that I got for my audit. It's things that I've highlighted. Involved as a lead is important, demonstrated positive change and completed 2 PDSA cycles, participating in all stages of the project, involved in planning, data collection, data analysis, and implementing change, and presenting it at a meeting. Obviously, you need to do these things to get a letter signed off by a consultant, but it's important to remember that you need evidence to show that you have done it, and keywords that are needed in your evidence. There's no point you doing all this work and then not having anything to show for it, because you haven't got, you know, the letter with these key terms in them. So it's important to make sure you have everything. And this is an example of the audit I'm doing currently. So it was about Glasgow IMRI scoring for severe acute pancreatitis. So it was auditing whether my local general surgical department uses the Glasgow score to diagnose and predict and escalate patients with severe acute pancreatitis. Turns out they were doing it quite poorly. It was about only 40%. So I put out some posters outlining the criteria for it, sending out an email, giving a talk at the local clinical governance meeting, re-auditing the data in 2.5 months, found out that it went from 40% to about 65%. And then I implemented a change on the electronic system, which I will then re-audit in about 3 to 4 months. All it took me was going up to my consultant, asking what needed to be done, if anything, he had any ideas, and the whole process is very, very easy. The audit department was very helpful. The Sunrise system, what they call it, which is our electronic system, it's very easy to make a change, a lot easier than you think, and I got a good 2-cycle audit out of it. And so, yeah, I hope you found that helpful. I will, if you have any questions, just pop it on the chat and we can answer it at the end of Mr. Abbas's talk. But yeah, thank you guys.
Thanks for the presentation. Abbas, would you kindly share your screen, please?
Yeah, sure. Let me just... Yep, can you see that?
We can.
Perfect. Oh, how do I?
Oh, if you put it in presenter mode, please.
Yeah, so I'm just doing that now. There you go. Cool. So my name is Abbas, and I'm here to talk about how to maximize getting the most out of your audit / your quality improvement project, really. Can everyone hear me okay?
We can.
It might be a bit noisy in my office, that's what I'm just saying. Right. So, just a little bit about myself, just so you guys know. So I went to university in Cambridge, then I did my F1, F2 in the Oxford Deanery, and I did my core surgical training in the East Midlands, and I'm now an academic clinical fellow in Nottingham. So a lot of my work is mainly research based, but over the years I have been involved in a few audit and quality improvement projects. So this is just a little sample of what projects I've been involved with, and you can see it's quite easy to accumulate lots of audits and quality improvement projects if you know how to maximize time. And actually, I think out of the 8 or however many projects I've done, I think I've gotten something like 15 or 16 international presentations out of it. So you can get quite a lot from your projects, but you just need to be quite dedicated and be quite smart about how you do them, really. So I think there's already covered most of this stuff, so I'm not really going to over labor my point, but essentially it's just really important to understand the difference, to really understand the difference. So an audit is just measuring compliance to a known guideline, and that can be any guideline you can think of, whether that's national, international, or even departmental, or even in just in the hospital itself. And then whereas a quality improvement project is looking at the overall system or way a system might work and trying to find ways where you can improve patient care or patient experience by making small changes here and there. So it's not research. So research is the generation of new data. And it's important that you make this distinction, because while audits and QIPs, as Naadir said, are a necessity in your foundation program and your core surgical training program in order to ARCP. And in fact, even as a registrar, I still have to be involved in audits and QIPs. You have a separate requirement to do research as well. That is a very different process. Okay. So how do you get an audit? So I would say the easiest thing to do would just be to speak to your team, really. Speak to your consultants, your registrars, even other medical students and foundation doctors, because actually a lot of the time, your colleagues or your friends will have projects going on that you can, and actually, as Naadir said, a project can be quite unmanageable when you're trying to do it by yourself, and sometimes it's a lot easier to have a friend help you out. And sometimes consultants will have ideas, but they don't have the time to necessarily do the legwork. Similarly, registrars, and I'm always happy to have a helping hand. And then, registrars and consultants. So I'm always very happy to be approached by my juniors if they have any ideas about projects. I'm always happy to support them. So generally, registrars and consultants are always very happy to help. And like Naadir said, there are always audit leads within your hospital, and most hospitals are filled with unfinished audits that you can always pick up and try and complete if you need to. Okay. But to be honest, I think the best way to get an audit really is to think of an idea yourself, because then actually it's something that you can talk about with a bit more pride. So although, as Naadir says, you get points for all these audits and QIPs, you often get asked about what you're most proud of. And if you have thought of the idea yourself, you develop the process yourself, that is always better than just piggybacking on someone else's idea. Obviously, not everyone's going to have an original idea, and if you can't, there's no shame in that. But it's always good to have some original thought. It also just means you're a bit more passionate about your work as well. which is actually important because audits and QIPs are long processes and they do require a lot of time and dedication. How do you pick a project? So the question in your mind really should be, what are you trying to accomplish? Are you just trying to tick a box for your ARCP or for your applications or whatever? In which case, you know, by all means, pick something easy, pick something quick, and pick something that gets you the points quickly. And you know, there are lots of audits out there, are lots of guidelines out there for almost every single specialty, both national and international, that we should be adhering to. So it's actually very easy to just pick a guideline, measure a department's compliance with that. You can then present your results in a departmental audit meeting, and you know, that's a couple of boxes ticked, and you can always re-audit it later down the line. Someone else can re-audit it later down the line if you're no longer with that department. If you actually want to make a change in the system, then that's a different thing. So that generally requires more effort, but it's a lot more rewarding. And if it's your own idea, then you know, then you need to develop that process yourself. You need to find a supervisor that's willing to support you, which, like I said, shouldn't be difficult to find, but it's all about what you are trying to get out of the project. If you want to get a presentation or a publication out of it, then it needs to be something a bit more exciting rather than sort of a simple audit about VTE prophylaxis or something like that. It needs to be something a bit more original, something a bit more cutting edge. Okay. The second thing you need to ask yourself is it possible for me to finish this project? So like Naadir said, you don't spend an infinite amount of time in your specific department. So you need to pick a project where you can either get the data relatively quickly and then work on the data later on, or you need to for example, you can work on a project continuously throughout a year if you work in the same hospital. I can keep returning to that department in order to keep accessing the data and keep accessing the resources you need to finish the project. So it's very common for audit and QIPs to be left unfinished because people rotate through that specialty. So you really need to think about whether or not you can actually reach the goal you want to achieve before your time runs out. And then the last thing really is, what can you get out of this project? Like I said, there's lots of different goals you can have. You can either just be trying to tick a box on a piece of paper and get the points you need, or if you're trying to actually achieve something and change patient experience for the better, and some people have done that. Or, you know, are you trying to get something a bit more out of it? So something like a national or international presentation. And, you know, there are always levels of complexity to audits and QIPs. And generally, the more complex and original a project, the more likely it is that you get something a bit more substantial out of it, like a presentation or a publication. How do you get it done? So what I always say to my juniors is that you need to set very firm deadlines and very firm goals. So if you say, you know, if we were to meet up today and you said, let's do an audit on X, then, you know, I would expect weeks in order to make sure that we keep progressing quickly and that we get the project done on time. What you have to do is leave it to the last minute, because so many people do that so frequently. And what happens is you'll get some of it done, but then leave the rest either unfinished or not handed over to anyone else. So the project just remains in the ether probably forever. What I always recommend is quite good is to have quite regular checkups with your supervisor to make sure you're progressing well. This can be done every 2 or 3 weeks, just to check that everything is progressing well. And if you have any problems, you can always speak to them directly. And, you know, often your supervisors, be it their registrars or consultants, because they've been in the department and they know the hospital so well, they'll know ways around your problems much quicker than you trying to solve it yourself. Lastly, if you've got a big project, there's no shame in handing it over to a colleague or a friend to finish it off, to someone who rotates in. But you need to make sure that the handover is organized, that there's always a set system in it over to someone who's not going to finish the work. Then what happens is you don't get anything and they don't get anything either. So it's kind of a pointless process. in that sense. Presentations and conferences. So there are lots and lots of presentations and conferences out there, and these range from a variety of different subspecialties at different levels. So there are medical student conferences, foundation student conferences, foundation doctor conferences, all the way up to international conferences. You shouldn't, if you're proud of your work, you shouldn't be afraid to put your project out there. What I always recommend doing is look ahead and target some conferences early on, especially if they're in the same field as what your project is in. Get an abstract written up early, and then you can then tweak that abstract specifically to the conference out there. So make sure you have an idea of when the deadlines are and get those abstracts in early. Don't be shy to ask your supervisors for help writing abstracts if they've done one before, because most of your supervisors will have written hundreds in their training. Okay. And the other important thing is, if you do end up going to a conference, it's always helpful to speak to your supervisors, because often conferences can be quite expensive. So it's worth trying to get funding from your department or from your or from the hospital. And supervisors often have an idea of what conferences are out there anyway, and they're very good at directing you to the appropriate conference for your project. And that's actually it from me, really. I just thought I would keep my talk short and sweet. And then if there are any questions that people want to ask, then I'm happy to sit here and be asked, really.
Thank you for your presentation. We've got a few questions. First one is for Nazar. How did you implement changes to the electronic system? Did you work with IT?
Yeah, so in my hospital, it was called Sunrise. They have a Sunrise department dedicated to the system. So all I had to do was send off an email, had a meeting with them, discuss what I wanted to do. It was easy to do, but it takes long to implement. So I think having that in mind when you're planning your project is important. I think I had a meeting with them in January, and the change has only just gone in. So, you know, it takes some time because they have loads of other things they need to do as well. Yeah.
Oh, another question. Can you have more than one lead on an audit?
So that's very much hospital and departmental policy. You can have co-leads, that's very common, but I would try and keep it to a maximum of 2, really. So I wouldn't try and do a 3-lead or 4-lead project, because I guess that's quite messy.
Okay, I don't think we've got any other questions, but if anyone would like to chime in, you should be able to unmute yourself if you've got any questions. Okay. Can you? Oh, one from Iggy. Do I have to do an orthopaedic audit to get into orthopaedics?
No, it's the short and long of it. If you look at the scoring sheet for core surgical training and trauma and orthopedic registrar training, they don't actually look at what your audit is about when they give you points. So they give you points on just audits in general. So I'm an orthopedic registrar now, and I think I only ever did, of the like 15 audits I did, only 3 of them were on orthopedics, I think. So I didn't have that many orthopedic audits.
Okay, I've got a request. If you could share the screen that showed the letter you had for recognition of your audit.
Sure. 1 second.
Thank you.
Yeah, so this is, I mean, this, if you go on your, if you're talking core surgical training, if you just go on the scoring portfolio thing on the website, it gives you the words that you need to have in your letter. But yeah, this is what I used.
Okay, and for audits, which close the loop, what's the minimum time you would recommend?
Maybe Abbas, if you take that, since you've done significantly more.
Yeah, sure. So it just depends on the complexity of your audit, if I'm being honest. And like I said, there are different levels to audit. So some audits, which are very straightforward, can be, can just be a day's work to get the data and another day to process the data and write up the results, whereas other more difficult audits can take a significantly longer amount of time. So it's kind of asking how long was a piece of string, really. It just depends on what the project is like. I would say is that you just need to be realistic. So if you need to get data from multiple different sources for a quality improvement project, then you'll need, I would give yourself a few months to do that, because there will always, especially if you're relying on other people to get data. Whereas if the data is freely available and easily obtained, then you can give yourself less time.
Okay, when can you get started with audits?
So I think I did my first quality improvement project when I was a medical student, I think. So I think you can start it at any time, really, but I wouldn't. My kind of advice would be to do it when you're if you're really keen to get started, is to start when you're a clinical medical student, really, so that you're already in the hospital you're at, where the audit is based, and then you can start, and then you can just liaise with either your consultants or your registrars and get something going.
Okay.
Yeah, I found that, yeah, similar. And I think first and second year I try to get involved, and it's quite difficult, when you're not really in hospital. If you're in the hospital itself, it's a lot easier. The thing I shared about my GP surgery, I think first and second years do quite a lot of GP. That's a place to start if you're really keen and just want to get involved in the process. But yeah.
Okay, thank you. Do we have any further questions? I don't think we've got any further questions. Have you got any closing words of advice to our delegates, please, guys?
So I think my advice really is to don't be shy. So I find that a lot of people just feel really awkward asking to be involved in projects or audits. Honestly, don't be, because we're always happy to be asked, and we're always happy to share the workload a little bit, and we're actually always very happy if someone has an interest in doing a project with us. So yeah, by all means, never be embarrassed or shy to ask.
Okay, awesome. So our next webinar is on the 7th of June on statistics, at the same time at 7 p.m. So please do join us then. And if you could all kindly log out of Zoom, please. Thank you.